Hi guys, here we go again, another lecture. This is on, we're going to start the pulmonary system, just a little bit of pulmonary pathology. We didn't get to a lot of stuff, which is pretty straightforward. I mean, when you review for boards, you could handle it. Pulmonary pathology is nothing like reading EKG and things like that, but I do have some other lectures on pulmonary on my YouTube channel, so you should watch those before boards. And here we go. Let's see, where is my little laser pointer is out. Off we go. So real quickly, we're going to cut most of this out, but we have to talk just a tiny bit. And we're going to be studying the lungs and the tracheobronchial tree, and that's what this is, right? These are the lungs. Which one's the right lung? Good job. This side, right? There's the superior lobe, inferior lobe, middle lobe is right here. Those are the fissures. And the left lung only has two lobes, the superior and inferior lobe. Very nice drawing here of the tracheobronchial tree, kind of superimposed with a kind of a ghost of the lung over it. But yeah, very cool. So notice that this is really like a tree. If this is the trunk of the tree, that's the trachea. Then we have the left and the right main stem bronchi or primary bronchi. Then we have three lobular bronchi, and that side two lobular, and they go smaller. We'll see an exact breakdown of this tracheobronchial tree, but it's literally like a tree. And if that's the ground, this is the root system. Maybe it's the trees in a little valley, so some of the roots have grown up. But they get smaller and smaller and smaller. So that's kind of the setup of the lungs. When you get way down, take a cross-section of it down to the very end of the smallest little roots. The very last part of the root system is the alveoli. And that's where most of the gas exchange occurs. Carbon dioxide is let out, and oxygen is cast out into the blood. And yeah, so that is the system. The microcirculation of the lungs I'm always talking about. This is the microcirculation. Right, here's I'm not sure which way we're going. I guess they're saying this is the pulmonary vein. So pulmonary vein would be oxygenated. That's why they made it red. So it's heading toward the left atrium. And this is coming from the pulmonary trunk or from the right ventricle. And it's blue, even though it's called the pulmonary artery. It's got deoxygenated blood in it. And yeah, so there we go there. And I threw this one in here because we're going to talk quite a little bit about the pleural space. But when you get into radiology, you need to know all about the pleural space. And there it is. There's the lung, there's the trachea, and the pulmonary tracheobronchial tree. Kind of in this cartoon, they left a lot of space so you can see this cavity here. And this is called the pleural cavity. Of course, it's not that big in reality, but it's created by similar to the heart and similar to the abdominal cavity. It's one of the P serous membrane levels, and this one's called pleura. So we have a parietal pleura on the outside, visceral pleura stuck to the lung here, and it makes a cavity. And that cavity has a negative pressure inside of it, and it helps inflate the lung, suck the lung up or out and keep the lung inflated. You poke a hole in that, and the lung will deflate. Right, we all know that from TV. Probably somebody gets stabbed in the chest and they get a collapsed lung because it's got to be a little more than that. They have a little flap. But no, if they get stabbed, it lets the air out and the lung will collapse some degree. Talking about a tension pneumothorax, when you get a little check valve and you take a breath and the air comes in, and when you breathe out, the air tries to get out and it can't get out, and you get more and more air. I don't know. I'm talking about that. That's like, we're not going to get to that. But anyway, there's a blow up of it. So parietal pleura here. That's the rib cage and the chest wall. And then we have visceral pleura that's stuck to the lung itself. Okay, here's a nice example of what can happen. So something called a bleb. They're like little herniations. Where's the alveoli? Let's go back to the alveoli. You can get a herniation of 1 or 2 or 3 alveoli, and they leak air. And the leaked air can form a little bubble on the lung tissue, and that's called a bleb. And the bleb can pop and start to leak air. This is an exaggeration. You would have to have a huge bleb, which is called a bulla, to do this, but if you leak air into that pleural cavity, you can start to fill the cavity up with air. And then the air has nowhere to go. It starts to push the lung in. So when the air gets in the pleural cavity, you have yourself a pneumothorax. Pneumo means air. Thorax means it's in your thorax. And the compression of the lung is called an atelectasis. You should know that. I do like that. Those are common words, high-yield words. So bleb, pneumothorax, atelectasis. You should definitely know those. Okay. Well, we'll get to talk a little bit about the two types of atelectasis in a minute. Let's go back to our pulmonary bronchial tree here, our tracheobronchial tree. And it actually has 23 divisions within that tree. They get smaller and smaller. Here's the trachea, primary bronchi. Those are the lobular, 3 lobular segments on the right and 2 on the left. And they get smaller and smaller. Bronchial, just like really roughly, the bronchi get smaller and smaller. They go to lobular bronchus or bronchi. Then they go to segmental bronchi. And once they get down to about here, they lose most of the cartilage. We have cartilage around here that keeps this tube open. I think I have another picture coming. But once we get down to the bronchioles, we lose a lot of the cartilage, and the tubes could collapse quite easily if it weren't for something called radial traction, and we'll talk about that in a minute. But the bronchioles go down to about stage 16, and that's the end of them. Those are called the terminal bronchioles, and there's no gas exchange that occurs there. Those are more conducting tubules, so that's called the conducting zone. Their job, this is just like the highway to get the molecules of oxygen into your alveoli or into your acinar system and to get the carbon dioxide breathed out. So they don't do much other than transport carbon dioxide and oxygen or air that you breathe. But once you get down to the last 3 kind of layers here, this is the acinar system, and they all have little sacs on them called alveoli. Even the respiratory bronchioles have a few alveoli hanging out on them. So a little bit of gas exchange even occurs within a bronchiole. So if you ever see a question, does gas exchange occur anywhere in the bronchioles? The answer is yes. In the respiratory bronchioles, a little bit of gas does exchange. All right, but not in the terminal bronchioles. That's a good little board, soft, easy board question. One of my questions, maybe. But the further you get toward the end of these things, the more sac-like they become. Then after the respiratory bronchioles, you have ducts. And off the ducts, you have clusters like grapes, bunches of grapes growing, and those are the alveolar sacs. Alveolar sacs are connected by these alveolar ducts, which also have quite a few alveoli coming off them as well. Okay, here's just another cartoon. So respiratory bronchioles are here. Terminal bronchioles have a lot of smooth muscle. The cartoon maybe is overdoing it a little bit. There's a little bit of smooth muscle because just like tunica media, there's smooth muscle inside the walls, and it can contract and squish down. So the most meaty of all of the bronchioles is the terminal bronchiole. In fact, it's like the arteriole. It has a lot of smooth muscle in the walls. And someone who has an asthma attack, it really affects these terminal bronchioles. All the bronchioles are affected, but it really hits the terminal bronchioles hard. And the air gets trapped. You can breathe the air in an asthma attack, but you can't blow it out because this is spasmed up. So that's the problem with asthma. And what's the adventitious sound for asthma? Good, wheezing. All right, so that's kind of all I wanted to say there, but this is the acinar system. Nice picture of it. Here's a very complicated picture of all the different bronchioles and all the different branches. But the point of this is I wanted to show you the trachea has these rings of cartilage. When you take a deep breath in, you get a very strong negative pressure, and it will collapse this tube if something's not holding it open. What holds it open in the bigger pipes is this cartilage. In the smaller pipes, what holds open, if there's no cartilage in the smaller pipes? Something called radial traction. This is a very important concept. So in a bronchiole here, here's a tube. It doesn't have any cartilage, so if you take a breath, this would collapse if it weren't for the substance or the parenchyma of the lung itself. Remember the lungs in Gross 2 lab? They felt like sponges and you could squeeze them and they're springy. Well, what you're squeezing, most of the lung tissue that you were squeezing on, that's the parenchyma of the lung. And a lot of collagen is too well, but there's a lot of elastic fibers that are hooked in to these bronchioles, and it keeps them open. So when you take a deep breath and it tries to collapse in, it's not going to happen because these bronchioles are surrounded and attached to the parenchyma of the lung. So everything is great until you get a disease that attacks the parenchyma of the lungs, because then when you take a breath, it collapses. And that's what emphysema is all about. And it's a damage, an attack on the parenchyma of the lung. Okay, one more concept here is the alveoli. If we get way down and see the capillary, the pulmonary capillaries, which is part of the microcirculation, there's the red blood cells. If you're oxygen molecule, you got 2 layers of endothelial to go through. Oxygen can diffuse, and carbon dioxide doesn't need any transporter. It just diffuses right out of the red blood cell or right out of the plasma as well, the blood fluid. So it can diffuse, it can diffuse right through here, jump into a red blood cell. Some of it jumps into the plasma as well and is carried. CO2, the same thing. CO2 can diffuse out. And it can also, it's a slow process. Remember, how does CO2 diffuse out? You guys remember that from physiology? How does it diffuse out? Come on. Bicarbonate, right? HCO3. HCO3 is inside the red blood cells and a little bit in the blood plasma as well. So HCO3 can, if you add a hydrogen to it, it'll turn into CO2 in water. So that's an important concept. So when you're kicking out CO2, there's no CO2 molecules floating. That's all in different forms, and you have to convert it to CO2. This conversion process soaks up hydrogen ion. So you could almost think of it as blowing out CO2 is kind of like blowing out hydrogen ion. It soaks up the hydrogen ion. Got another slide somewhere on that. Another concept we should talk about is pulmonary edema. So if you get a beaver dam, aortic stenosis, mitral stenosis, a failing heart, those are all beaver dams in the heart. The blood can't get through the heart, so it backs up in the microcirculation of the lungs. Too much pressure here, so some of the blood fluid in red starts leaking out of the capillaries because there's too much pressure. And it can leak out through both endothelial layers. There's not much, just a really thin little basement membrane here around epithelial cells. It can get right out of there and start soaking into the alveoli. And in fact, if enough of that soaks into the alveoli, you're going to start coughing up blood. It'll be like a white, pink, frothy, foamy sputum. That's called hemoptysis. Okay, so that's another important concept. I do like that question. We're not going to get into it any deeper than that, but you should know that. Oh, this slide's out of place. But this is Armando, I forget his last name. He's back in the mid 2014 or so. I don't think he still does them, but he was a medical student. He did some wonderful videos. He did a great job explaining this. So it's a screenshot from his video, but it's really nice to show the way bicarbonate travels. It travels in the blood. It travels in the red blood cells well. Most of it travels in the red blood cell. This is how carbon dioxide, some carbon dioxide hooks up to hemoglobin as well. So that's 3 ways carbon dioxide can travel in the blood. It never travels by itself. And when in the microcirculation of the lung, it can do 2 things. Some of it grabs a hydrogen ion, no enzyme here, it's slowly converted into CO2 and water. CO2 diffuses right out. This is the alveoli here, the sac. Some of it will diffuse back in, or most of it actually diffuses in exchange for chloride. It diffuses back into the red blood cell, and it meets a hydrogen ion here, and then with the help of an enzyme, carbonic anhydrase, super quickly it's converted into CO2 and water, and the CO2 can diffuse right through all these membranes and jump right out like that. That's how CO2 is released. Some CO2 is bound by hemoglobin inside the red blood cell as well, and that's split off the hemoglobin, and there's the hemoglobin CO2 molecule, and that's split off as well. And yeah, the CO2 just diffuses out. And there's how oxygen, some oxygen can be transported naked in the blood plasma. Most of it goes into the red blood cell, binds with hemoglobin, and you have an oxyhemoglobin plus a hydrogen ion. Well, that's not wasted because that hydrogen ion is grabbed by the bicarbonate here and used to dump off the CO2. So I'm sure this is old hat to you, but if you don't know stuff like this, physiology boards, you got to know stuff like that, right? All right, so enough messing around. Let's get to obstructive lung disease. So just like supraventricular tachycardia, obstructive lung disease is an umbrella term. It has many little children underneath it, including COPD. But we'll look at all the children here in a second. All of these are chronic and incurable. You can't cure these diseases. All of them progress at varying rates. Some of them progress so fast they become fatal, and they can be very difficult to manage. And they are not, this is not like Marfan syndrome. These are very common. They're perhaps surprisingly, they're the second most common cause of permanent disability in the United States, according to the Social Security Service. Number one is heart disease. In the world, the prevalence of this problem is 16% of obstructive lung disease. So it's a pretty crazy number. The mortality rate is on the rise despite better education and better treatments. It's still on the rise, so it's not a good disease to develop this. And categorizing these things is different because they do tend to overlap. So it's not as simple as perhaps some of you have learned in other classes. So here are the categories of obstructive lung disease. COPD is a child under the category of obstructive lung disease. It stands for chronic obstructive pulmonary disease. That has two subcategories, emphysema and chronic bronchitis. Some big medical texts are now including chronic asthma in this cluster. Another one is chronic asthma. I have a video on the YouTube video you should watch before boards on that. We're not going to get to any of these this quarter. Bronchiectasis is another big one here. Chronic tracheal obstruction from maybe congenital stenosis or maybe a tumor. There's things that can do that. Chronic bronchial obstruction is the same. But these are all forms of obstructive lung disease. They all have one thing in common. They obstruct the lungs. So there's airway obstruction here. There's three ways you could, very similar to the intestine. Did we talk about block? Maybe we're talking about that tomorrow. But nevertheless, there's three ways you could obstruct the tube. So you can have a problem inside the lumen where the tube is okay, but there's gunk clogging up the tube, like excessive mucus for someone who has chronic asthma or chronic bronchitis. They have lots of mucus. You could have a problem not with the lumen, but inside the wall of the tube, and it makes the wall get really big and beefy. So people with asthmatics, chronic asthma, people get smooth muscle hypertrophy, and some of the mucus glands get really big because they're being used all the time. Or maybe nothing's wrong with any of that, but the problem is an adjacent tumor in the lung tissue or a lymph node that's compressing the lung tissue. So bottom line of all this stuff, they all obstruct the airway and they make it tough for the person to breathe. Here's just kind of driving that point home. So here is an example of mucus inside the lumen of an otherwise normal bronchial. Radial traction is still, the parenchyma of the lung is grabbing this tube, so everybody's good. Here is an enlarged lymph gland, or not lymph gland, but here's a mucus gland and an asthmatic. And the muscle is really big because he's constantly triggering that muscle off. And it's got a permanently decreased lumen because of this. And then here's a patient with emphysema, where the disease attacks the parenchyma of the lung. And therefore, without the radial traction, every time he takes a breath, the tube collapses. Right? I could have drawn a tumor in here as well. That would be another outside force affecting the size of the tube. Okay, I guess we're going to talk more about it. So interluminal obstruction. So just everything I just said, excessive secretions like mucus from conditions like chronic asthma. I forgot cystic fibrosis. How could I forget that? But these conditions, all three of these conditions, these guys overproduce mucus, chronic bronchitis and asthma. Cystic fibrosis doesn't overproduce mucus at all. The normal mucin secretion rate is normal. The problem with it, there's no water to dilute it, because mucin needs a certain amount of salt water to make it manageable. People with cystic fibrosis, they don't have that water, so their mucus is tenaciously thick and sticky. And in fact, I think we're going to fall down a rabbit hole. The problem, how come they don't have diluted mucus? Why is it so sticky? How come the water hose isn't working? It's because the water hose is really something called a CFTR channel, and there's a genetic mutation. There's all sorts of mutations, but we'll talk about the most common one. So yeah, let's fall down the cystic fibrosis hole real quick. We're not going to go crazy into this, but I'll just talk about the lung part because that's more my domain. I'm sure you've learned about this in other classes. Watch out for this weird AKA. Robbins calls it mucoviscidosis. So I'd never heard that word in my life before until I read Robbins. But Robbins is a board book, so you better know that. Hopefully they'll just call it cystic fibrosis, but you never know what's on boards. This is to white people. This is a really nasty disease. It's the most common lethal genetic disorder in Caucasians, period. 95% of the time, you go to a hospital and you start picking out cystic fibrosis patients, 95% of them are Caucasians, white people. Prevalence is 1 in 2,500 births. Somebody could run the math on that to see what percentage that is, but it's, I don't know what it is. Now it's going to bug me. Is it like Marfan's about? I'm sure some of you have already got it, but 1 divided by 2,500, sorry, oh gosh, I screwed that. 1, 2,500, yep, so it's 0.04. Marfan's is 0.01, so it's about 4 times more common than Marfan's syndrome. Not super common, but it's more common than Marfan's. The average life expectancy, bummer. Even with today's modern medicine, it's only 30 years. They typically live to about 30. What causes it? So you should definitely know it's an autosomal recessive. What does that mean, autosomal recessive? 1 or 2, both mom and dad, the gene at that allele. So mom and dad have gene A, or the genes that, because we all have double copies. We have 2 genes with the DNA instructions to make everything, and both of these genes are mutated. We'll look at the gene here in a minute that does that. So it's autosomal recessive disease. Both homologous genes, mom and dad's chromosomes, they're mutated by knockout mutations. And yep, the symptoms usually show up. The classic sign, I used to teach this in dermatology. I was told not to because you learned it somewhere else, so I don't anymore. But the classic discovery of this condition is mom kissing her baby, and she kisses the baby and it's like really, really salty. Why is it so salty? Because the CFTR channels are destroyed. It works a little bit different in the sweat gland. But it holds water again, and the salt is super, super sweaty. That's not a good sign. Let's see. What is the cause of cystic fibrosis? It is caused by a dysfunctional CFTR chloride anion channel. And these CFTR channels live in the epithelial lining of ducts and tubules, like the bronchial tubules. In the tracheobronchial tree, you can find them. In the gastrointestinal tract, in the epithelium, scattered in there. We didn't talk about those, but they're there. In the pancreas, they're there. I mean, people, you can get plugged up. These all create a thick and super tenacious mucus. So just think in every one of these, if you get mucus plugging up the glands, like in the pancreas, what if you can't, in the main pancreatic duct, you can't get pancreatic juices out because it's plugged up with gunk, thick mucus. I mean, you could get pancreatitis, all sorts of trouble. But for us, what is it going to do? It creates a thick and tenacious mucus in all these organ systems. Normally, these CFTR channels are inserted in epithelial cells. We said that already. And their job is to really, they're like the water hose in a way. They indirectly dump water into the lumen of the duct. Why do I say indirectly? Their job is to move chloride from the cytosol of the epithelial cell into the lumen of the duct. Who follows chloride ion? Like a puppy dog. Don't say water. Sodium chloride, they go together. Sodium follows chloride, now say it. Who follows sodium like a puppy dog? Water. So that's exactly how it works. I guess I said it right here, didn't I? So you got to have water to combine with mucin to form mucus. So here's another YouTube video. Let the guy do the drawing. I did a really good job on this. Sorry, I forgot to put the link up here. Was this Armando? I think this was Armando again, actually. So a normal CFTR channel in the epithelial lining. So there's our CFTR channel, and its job is to move chloride ion out. This is the cytosol. This is an epithelial cell here. Just kind of see a piece of it. This is the lumen of a bronchiole, small bronchiole. And we have goblet cells not shown, and we have mucus glands, maybe up here somewhere, cranking out mucin, sticky stuff. And that's got to be combined with water. And so it's a little more complex than this, but I'm just making it simple. Chloride ions are shot out in here. Sodium follows, water follows, so they all mix together. And you get kind of a two-layered sort of mucus layer over here we'll look at here in a second. Right? So how is the CFTR protein channel made? Well, of course, there's a CFTR gene for that. And specifically, it lives on chromosome 7. We won't go any deeper to that. But the central dogma, how do you make a CFTR channel? Well, you open up the chromosome 7, you open up the genes that hold the information. RNA polymerase comes in there and reads that template strand, and it spits out an mRNA molecule which swims out of the nucleus. There's a bunch of stuff that happens to it. It gets spliced and some things. But it swims in the cytosol, looks for someone who can read it and understand it, and it turns out to be a ribosome, of course. Ribosome will read that mRNA, and it's translated into a CFTR chloride anion channel, and then it swims over and inserts itself into the epithelial lining. Here's the problem. Now there's 6, 7, there's probably even more by now, but there's a bunch of mutations with the building of the CFTR channel protein, things that can go wrong. By far the number one culprit is a delta F 508 mutation. You need to know that. I've asked that before, and I will ask it, and boards could ask that. Delta F 508 mutation on chromosome number 7. Not so lucky number 7, right, this time. And yeah, that'll do it. Specifically, it's a deletion mutation where a phenylalanine, remember the abbreviation F or PHE, phenylalanine is taken out of the codon, and yeah, you get a mutation. Just one amino acid is messed up, a deletion of one phenylalanine, and will screw up the protein. It'll actually work, but it's folded in a way that makes it not be able to be transported into the epithelial lining. So it's missing the phenylalanine. The CFTR channel protein doesn't fold right, and therefore when it goes through the rough endoplasmic reticulum, has a quality control region, it doesn't like the looks of it, and it stops most of it from being produced. If it gets out, experiments, they've taken it out, they've destroyed the endoplasmic reticulum, so it bypasses that, and it works. So it still works, but the trouble is it doesn't pass quality control. And maybe some of them, to different degrees, maybe some patients have a few of them that are working. The less you have, the more severe your case is. And then again, CFTR channels, super important for hydrating the mucin, making a normal kind of watery mucus. Without CFTR channels, the mucus is super, super sticky, thick, dehydrated. It's just a mess. And therefore, your mucus escalator is basically screwed up. Remember the mucus escalator system. Let's take a look at that in case you've little histology refresher. Remember that this is a bronchiole right here, but this is true in other ducts as well that have mucus. But actually it's not. This is specific. This double layer, to my knowledge, is specific to the tracheobronchial tree. So you actually have goblet cells. There's goblet cell right there, and you have mucus glands. There's a mucus gland, and they secrete two types of mucus. They secrete a really watery mucus. This is where you really need those CFTR channels. That's called the thin layer of mucus, which is in lighter gray. It's thin enough that the cilia can still beat. Remember, we have cilia kind of sweeping up toward the voice box. Oh my God, my mind's blanking. The epiglottis covers the, oh man, brain fart. How could I forget that? My brain's making too many of these videos. The larynx, oh my God, larynx. So you're sweeping up toward the larynx. You're sweeping this way like the arrow goes. But you don't want to make this mucus so thick that it paralyzes these cilia that are pushing all this gel and the thin and thick layer together. On top of the thin layer, you have a much thicker mucus. In fact, this is almost like, this is super thick. It's so thick, it's like fly paper. It traps the bugs, traps dirt and dust and foreign materials, and great. So as long as this is thin enough, the little cilia will sweep all this gunk up to the larynx, and then you have a choice to swallow it down the esophagus or cough it up and spit it out. That's the way a normal system works. People with the CFTR problem, if they don't make enough water, this thin layer of mucus, also called the sol, the thick layer is also called the gel layer. They can't sweep it. It's so thick that these don't do anything. So the bugs don't do anything. They sit here still trapped, but they breed like rabbits. And pretty soon they can dig in and start burrowing in to the wall of the bronchial tree, and there's blood vessels in there, to the bronchial walls of the bronchus and bronchioles, and you can get a rip-roaring infection, and now you got yourself a pneumonia. I think I got way ahead, didn't I? So what does the sticky mucus do? Sticky mucus progressively clogs up the bronchial tree. It screws up the mucus escalator and everything I just said. Too many bacteria causes an inflammatory response, destroys the bronchi, decreases the ability to oxygenate the blood then. right? If you got a mucus, because think of this is an infection here. These guys are breeding. Some of them are down here. It's caused an infection. Some of the exudate from the infection is filling this tube up. So it's also cutting off some of the ability to breathe. So too many bacteria cause an inflammatory response, ultimately destroys the bronchi, decreases the ability of the lung to oxygenate. It's a terrible death. People literally suffocate to death with this. They can also get septicemia. If the bacteria makes it all the way into the bloodstream, you could get septicemia and die that way as well. Okay, out of that rabbit hole, sorry about that, but I need to throw that in there. We're talking about COPD, and we're talking about ways that the tracheobronchial tree could be obstructed. We just talked about stuff on the inside of the lumen, like super thick mucus, or even regular overproduction of regular mucus can do it. And now another way is intraluminal obstruction. Pulmonary edema we talked about. If you got a beaver dam in the heart from a failing heart or stenotic aortic stenosis or mitral stenosis, you can get blood fluid dripping out and starting to clog up the small portion of the tracheobronchial tree, and you can't get blood if it's all clogged up with blood fluid. Right? We already looked at this, so I won't go through that again. Just another really nice picture, though, of the beautiful example of the microcirculation here and the pulmonary capillaries or alveolar capillaries. Yeah, failing heart, this all backs up, and you can dump tons of fluid, right? Like this picture here. If it really backs up, I mean, like this picture, now we got tons. We got blood in the bigger bronchioles because of this, and you can't breathe because it's taking up space. Okay, patients will have dyspnea, trouble breathing, especially on exertion, and hemoptysis, spitting up of blood. What about a physical squishing of the bronchial tree? We're still talking about intraluminal obstruction. Well, what if you choke on something? What if we've all had some water go down the wrong pipe. What if you swallow something and it cough at the right time and it goes down the wrong pipe? Here's a piece of, an egg-shaped piece of metal this guy somehow swallowed, it's a kid, right? Swallowed it and it went down the wrong pipe. So that can cause a physiological blockage of the flow of air there. So that's another intraluminal obstruction. How about an interwall obstruction? We talked about that already, but that's just people with asthmatics. They use those muscles a lot, and they get hypertrophic and really buff from working out so much, and they narrow the lumen because they're big. And the mucus glands also get worked out a lot, and they get really big, and they are in the substance, or they're in the wall of the bronchioles, and that takes up space and also compresses the lumen because of that. Inflammation can also do the trick, and the same thing. People with chronic bronchitis, chronic asthma, they can get an inflammation in there as well. Especially these people with chronic bronchitis and asthma, they overproduce mucus. It's not tenaciously thick, but they just produce too much of it. Remember that. I won't go down that road. We'll leave it at that. Or you get a viral infection or a bacterial infection, right? These can all cause inflammation, which causes edema, which there's no room for as much oxygen if you got fluid, exudate floating around in there. Okay, what about peribronchial obstruction? Something squishing the pipe from the outside. That can do it too. So what if you got a lung tumor smashing in the parenchyma of the lung? That's going to be smashing a whole bunch of bronchi, and you're not going to be able to breathe downstream. Whatever those bronchi that are smashed, whatever alveoli they're connected to, aren't going to work very good. So you'll have trouble breathing. Or if you get a hemorrhage in the lung tissue, anything that squishes the lung tissue from the outside, like a lymph node enlarged, or infection outside, anything that squishes. Or, as we already talked about, if you have a disease that rips up the parenchyma of the lung and you lose that radial traction, take a breath and your tubes are going to collapse. Here are some pulmonary chondromas from a patient. who came in having a lot of trouble breathing when she went up the stairs. Took a radiograph. What do you see? I hope every one of you sees that. You should not miss that. Yeah, we got some gigantic tumors here. So not good. These tumors are compressing, especially down here on this side. They're compressing enough of the lung tissue where the pipes are getting squeezed, and she doesn't have full oxygenation power. She's lost a chunk of her breathing power. So when she goes up hills or goes upstairs, she can't get enough oxygen. Loss of radial traction, we talked about that already, but I already talked about that, pretty much everything I said. Lose radial traction, when you take a breath, the tubes collapse and you can't get air in there. Talked about that a lot. Already showed you that picture. There's just another picture of that. It's an important disease. Let's see, what can destroy the lung parenchyma? We already said emphysema. There's other diseases more rare, but emphysema is the key one. Remember, emphysema is part of COPD, right? Chronic obstructive pulmonary disease. So the board question could say, what causes a loss of radial traction? Emphysema? True. COPD? Well, COPD, emphysema is part of COPD, so that would be true as well. All right, we talked about that. I don't know how many times I'm going to show you that. I guess I could take some of those slides out next time. But there's just the radial traction. You have an autoimmune attack against some of the proteins in this elastic tissue, and it inflames and rips up the parenchyma of the lung. There goes the guy's taking a breath. His bronchial is collapsing because of that. Okay, let's talk about COPD, and then we'll call it a quarter. So this is COPD is under the category of obstructive lung disease. It's also an umbrella term because it contains emphysema and chronic bronchitis. You medical people who are watching this, check what book is governed by your boards and see if chronic asthma is included. It might be included as one of the children underneath the category of COPD. For chiropractors, it's only emphysema and chronic bronchitis, that's it. In reality, with patients with COPD, I want to say it's almost impossible to have pure emphysema. There's always a mixture of emphysema. There's always some chronic bronchitis. You could be emphysema heavy, you could be chronic bronchitis heavy, but there always seems to be a mix of these two. That's why they clumped them under the term COPD. Very rare to see one all by itself. Both of these are irreversible, fatal conditions, although the rate of deterioration all depends on the patient's health and things like that. You can live quite a long life with COPD, but at the end it can, for me that would be a bad way to go, right, where you can't breathe. That's not a good way to go, I don't think. There are some classic signs and symptoms: dyspnea, especially dyspnea on exertion, chronic cough, especially with the chronic bronchitis patients, cough like crazy. Exercise intolerance, they don't do well. Sometimes they do okay sitting around the house, but get them walking and stuff, and they're like coughing and puffing and coughing. And the symptoms, unfortunately, do tend to get worse with the passage of time. Another 2 rabbit holes in this last lecture. So some classic imaging findings. We have atelectasis, which we already said is a collapsing of the lung. There's 2 ways you can collapse that lung. And then you can get lung overinflation, which is seen usually with emphysema. Okay, atelectasis is up first. So there are 2 types. You definitely need to know this for boards and for me and for radiology. There's 2 main types of atelectasis. There's one that's called a compression atelectasis. Perfect example is a tumor in the chest wall, and it pushes in. It could be a tumor inside the lung tissue where it compresses the lung. It doesn't have to be outside. It could be air in the pleural cavity filling up like crazy. If you have a chest puncture with a check valve and it fills up with inspiration, you can crush the lung from the outside. That's a compression atelectasis as well. anything that crushes these tubes, compression atelectasis. But here's the common one, and this you might not know this one. This is called an obstructive atelectasis, aka reabsorption atelectasis. Very common, switched back and forth. You need to know both of those two terms. So this one, I'll tell you right now what happens. So let's say you had an asthma attack and you had a whole bunch of mucus, and it just you couldn't cough it out, and it's stuck in a pretty good sized bronchus. What's going to happen to the air downstream from the bronchus? Well, it's going to get sucked out by the microcirculation. You don't show the alveoli, but they're down here. So the air is the oxygen is kicked out. Some CO2 takes its place, but nothing takes the oxygen's place. So you have a decreased volume. You only have CO2, a little CO2 here. Normally you would have CO2 and oxygen at the same time, bigger volume. So it literally sucks in all the tissue that bronchus connects to. And if you have a whole bunch of these things, it can literally suck the lung tissue in from the inside out. That's called a resorption atelectasis. That can happen from a LEGO, it can happen from a mucus plug, could happen from a tumor. I mean, so in a way you can get kind of you could get a form of compression. Now that makes me think, I wonder if compression should only be from the outside. Because if you had a tumor in here and it pinched off that's something you can ask Dr. Skalski or Dr. Hook when you get there. My understanding is you can have it on the inside, but anything that compresses, this has got to be stuck for a reabsorption atelectasis. It has to be something clogging the tube from the inside out. That's what we're going with my test. Okay, everything I just said. Right, everything I just said. So something completely blocks the airway, it won't collapse, air gets sucked out, can't get replaced, it sucks things out. 55-year-old patient with chest pain and dyspnea, long history of COPD, comes in, says, my back hurts, I want an adjustment. You say, we better take a chest, having a cough, let's take an x-ray, let's do a chest film just to see what's going on. What do you think? Do you adjust them? No. What do you do with them? Send them to the ER, right? They have a collapsed lung. They got a reabsorption atelectasis here. In fact, you can see exactly, there's the oblique fissure right there. So it's isolated to the upper lobe. It's all sucked in. So they got a reabsorption atelectasis going on there. Right? Patient had chronic bronchitis. The lung collapsed up here. It was a glob of mucus that clogged up a pretty large bronchus, and all the air got sucked out, and therefore air makes things black, right? The photons can zip right through that. That's all collapsed tissue. So that's a good example of a reabsorption atelectasis. All right, so back to COPD, third leading cause of death in the United States, only behind cancer. Everybody forgets about the lung diseases and heart disease. Prevalence is about 6%. It's probably higher now with the baby boomers. Caucasians, we've said, I think already, Caucasians are really the target of this disease. In 1999, a 10-year study found 80% of the deaths were of Caucasians from COPD. So these people are usually heavy smokers, especially the chronic bronchitis patients. But not always. Some people get COPD and they never smoked in their life, but that's not the norm. The norm is that they've been heavy smokers. There's two typical classes. I hate teaching this because it's obsolete, but I know it is on chiropractic boards, so got to teach this. And I know you've had this before. We got COP type A and type B, the pink puffer and the blue bloater. Remember that? In reality, these guys always mix like that. So classically, though, it's taught that COPD A patients were not super symptomatic. The A stands for the A right here, emphysema patients, and the B, these people were very symptomatic, bronchitis, the B goes with B here. And that's absolutely ridiculous, right? You can have people, horribly symptomatic people with emphysema, and they die from this. So it's kind of a ridiculous classification system. Nevertheless, I will teach it to you. And in reality, most COPD patients have both types of A and B kind of mixed together. Furthermore, some patients with A can be severely disabled and die, as I just said. So the A and B subtypes are no longer recommended to be taught. Weinberg, which is a wonderful book, 6th edition, Principles of Pulmonary Medicine, goes on a rant about how silly this is. Nevertheless, still in chiropractic boards. Okay, so here we go. There's the pink puffer. So COPD type A, pink puffer, classically male in his 50s. Well, the blue bloater's a male in his 50s too. Shortness of breath comes on over the last 3 or 4 years, especially in the wintertime. He's a smoker. He's pink because he's not cyanotic. He's not so, see, this is how the old saying, he's not so bad that he's turning cyanotic because he's not getting enough carbon dioxide exchange, or carbon dioxide in O2 is still working okay. So pink means he's not going to be blue color. He may or may not have a cough. And this may be true more for emphysema patients. They could cough, but it's not like a gigantic problem for them. If they do cough, it'll be white and clear. It won't be green and stinky full of bacteria like with the chronic bronchitis patients have. Cyanosis, the blueness, as we said, these are pink puffers, so they're not going to be cyanotic. You do some blood gases on them, they have normal levels of O2. They don't have acidosis because they're still able to excrete or push out CO2. Remember, to make CO2 from bicarbonate, you suck hydrogen ion out of the blood. If you auscultate these patients, they're usually fine with auscultation. Body for morphology, the A, of course, or body morphology, they tend to be really skinny. According to this old system, that's called an asthenic build. Asthenic build. Make sure you know that. That's been on my test before. And these patients have chronic emphysema. And the type A goes with emphysema. That's how I remember it. In advanced COPD type A, now I added advanced just to make sense of this, right? Because how can they be not having any trouble when they have all these horrible signs? So in advanced COPD, these are the ones from emphysema, in other words. They can have so much destruction of the parenchyma and alveoli that they actually coalesce together. Let me see do I have my drawing tool? I do. So if we have, let's draw a couple grapes. Here's a couple alveoli living, and there's their bronchiole there. With emphysema, it destroys the parenchyma between them, and it causes inflammation, and it ends up, because these guys are pressurized, it ends up popping the walls here and rupturing the walls between all these guys. So then, instead of that, you get something like this. And it stretches because it's overpressurized. And it doesn't work very good, but that's all air. And so that's actually going to increase the volume of the lung to the point they start becoming barrel-chested. All right? So barrel chest, think immediately, think emphysema, or COPD type A, emphysema. Okay, so the lungs get overinflated. In fact, one of the treatments for that is to cut out that dead tissue, and it takes some of the pressure off and lets them breathe better, so they can do partial lung removal to take out that dead tissue. These people have trouble breathing in the end stage because of all the dead alveoli don't work very good. You'll see them with something called pursed lip breathing, maybe even accessory muscles going to help them breathe. Here's a video on pursed lips, but it's like the monkey kiss. It makes the pressure a little more constant in the tracheobronchial tree, kind of helps them breathe. Here is a normal view, a little refresher. Looks great. What do you think of this? Patient with severe emphysema. This is no good, right? The heart is squished, so narrow mediastinum. Look at the hemidiaphragms. They're pushed way down too far. So here's pretty much normal lung tissue up here. What about down here? It's all dead. It's all coalesced like that thing I drew. So this is worthless tissue. They could have this all removed, and that might increase the quality of life until more of it went. I mean, this is a fatal disease, right? Yep, everything we said. Classic COPD type A for emphysema. Okay, type B, blue bloater, also male in his 50s, is also a smoker. These guys are really usually super heavy smokers. They have a productive, nasty cough. Their mucus escalator system is destroyed by the chronic smoking. They wake up in the morning and cough and hack it up because they don't have an escalator to get all that gunk out of their lungs. Their cough is associated with a expectoration. That's a nice way to say gunk that you cough up. And it's foul smelling. It could be green from bacterial infections. Yeah. Why is the chronic cough? What's the deal? Why do these blue bloaters have such a cough? What's the B stand for? Type B. Bronchitis, chronic bronchitis. Well, as I said already, their mucus escalator is destroyed. Why is their mucus escalator broken? It's because they don't have CFTR channels. Got nothing to do with them. Their problem is the cigarette smoke has bombarded the normal linings of all those tubes, which are normally filled with pseudostratified columnar, ciliated pseudostratified columnar, right? And the body is sick of being inflamed by it. And it says, okay, we're going to do a tissue swap. And that's the end of the cilia. It's replaced by something stronger, like stratified squamous. Multiple layers can handle cigarette smoke. But you lost your cilia. You just lost your mucus escalator. So you don't have any way to get bacteria and viruses and soot from the air or whatever. You can't get it up anymore. The only way to do it is to cough so hard your head's going to explode. We've all seen people like this, right? And yeah, they don't have a mucus escalator. And if the bacteria hang around, they're going to breed like bunny rabbits, and we're going to get ourselves some wicked infections. And that's what these people are constantly battling pneumonia because their mucus escalator system is wrecked. So there's the bugs. The escalator system's broken. They're all hanging out, and they're going to start breeding pretty soon. Okay, there's the laryngopharynx is where you can cough or you can either swallow it, or we already talked about that. There's another, we already showed you this thing, where the CFTR channels are in the ducts of the mucus mucus glands, right? There's nothing wrong with those CFTR. Only, in this they're fine. They're not mutated. There's no chromosome 7 problem or anything like that. So it's only cystic fibrosis has mutated CFTR channels. Okay, so we already said this. The expectoration, the spit up has been getting worse. It used to be only during the winter times, but now it's all year round. And they have attacks in the morning where they are fighting and coughing so hard they might rupture the blood vessels in their eyes. And it's green and yellow and full of bacteria because the bacteria are breeding like crazy in there. Exertional dyspnea because of all the gunk and chronic inflammation. They can't walk up the stairs. They can't supply the body with enough oxygen to do much stuff. Patients are usually really long history of smoking, 20 pack years. Should know what a pack year is, easy board question. Pack year is the number of cigarettes or cigarette packs per day multiplied by the number of years they smoke. That'll give you the pack years, usually at least 20 pack years. Okay, chronic infection, we already said this, damages all the microcirculation around the alveoli. No, I didn't say this. So the chronic inflammation from all those infections can get into the microcirculation, and it can scar up the microcirculation, and that acts as a beaver dam. We've talked a lot about this before, but that is the major cause of cor pulmonale. So it's really the cor pulmonale. It's really caused by the the COPD, chronic bronchitis type of COPD, as opposed to emphysema, although that can scarp the microcirculation too, in just a different way. And we know cor pulmonale is right heart failure, secondary to a problem with the lungs. What's the number one cause of right heart failure? My class better know that. Good, it's left heart failure. So if you got aortic stenosis, a beaver dam, or the heart's failing, you got a beaver dam in the heart, and you wreck your right side of your heart trying to push blood into that damaged heart. Is that called, do you make the diagnosis of cor pulmonale? No, because it didn't come from a lung condition. Patients got to have COP or one of the other lung diseases to have cor pulmonale. My people know that. You better know that. Chest radiograph. So if they have cor pulmonale, well, the right atria and ventricle are going to be puffed up like marshmallows from being overworked. They might have some congestion in the lung fields. And what about the EKG or ECG? Right? You better, that test is coming, right? That's coming. Well, this is all coming on the test. So they're going to have, it's going to swing clockwise. They're going to have a right axis deviation, right? Check out this soft tissue chest film. How's that look? That doesn't look good, right? So huge right here. This is not left ventricular hypertrophy, would be down here at this corner. This is right ventricular hypertrophy. The right ventricle has rolled over on itself, and therefore it gives that weird look. And we'll let Dr. Hook handle this from here on out. Oh, this is my domain, though, isn't it? What do you make of this? Oh, I covered up the history with this. Could be anyway. Patient with chronic. Well, I wouldn't even give it to you. I'd just say patient came in for an employment physical. You did an EKG. What do you think? The patient said there's nothing wrong with them. Two things you better notice. I don't think I wrote one down. Two things you better notice, right? Oh, good. Somebody got it. So right atria must be way too big. Right atrial hypertrophy. Look at that gigantic P wave. It's way too big. Way too big. So got to have right atrial hypertrophy to have that. What else? Good. Somebody spotted it. Look at limb lead 1 shouldn't be biphasic. Right? That's stick your arm, like airplane wings, stick your arm straight out 90 degrees. Your left arm, that's 0 degrees. That's limb lead 1. Well, if that's, oh, I can draw, right? I got my little drawing tools. Let's draw it. I think I can do it for you anyway. Let's do it right here. Let's go through it. You know these are coming on the test, don't you? There's 0 degrees. What's normal? There's 90 degrees. So that's a normal axis. Usually heads toward the southwest. All right. So what limb lead? We're going to find the axis of the heart. What limb lead are we going to look at? Good. Limb lead 1. All right. Where's limb lead 1? Where's its eyeballs? It's over here. There's limb lead 1's eye. Okay. So draw its line of vision straight across like this. Now, draw perpendicular because this wave is semi-perpendicular or semi-biphasic, right? So let's just for now draw perpendicular. That would be perfectly biphasic. If it was perfectly biphasic, this would be the direction of the current. But would it be this way or would it be this way? How do we tell? We're going to have to look down here. Who's a limb lead down here? That's the peeper, AVF. If it's positive, the current is heading right at it. Is it positive? QRS complex positive? Absolutely. Yeah, so we know what's going on. We could double check. I bet AVL is over here. I bet that's going to be mostly negative. Yep, AVL is mostly negative. So now we know the direction of the current. The current is going this way. Now we can look at the waveform and say, is the upright portion of the wave bigger or is the down portion bigger? This is small, right? This is way bigger. So is the current heading more, from perpendicular perspective, is the current heading more toward the limb lead one, which is the star of the show, or is it heading more away from it? It's heading more away from it, right? That's the rule. So actually, we could even cheat and say, look at limb lead 3, it's almost all upright, and AVL, which is up here, it's almost all down, so we pretty much know the current is heading like this. So is that a normal? So that's the axis of this person's heart. Is that normal? No. For our purposes, it has to be between 0 and 90 degrees. And it's not. It's shifted clockwise, which is called a right axis deviation. Got it? Make sure there's going to be guaranteed. Ooh, I wonder how could I do that on the new test format? Oh, I can still put a picture in there. That's right. I just did that with spinal anatomy, right? So that works. I can paste stuff in there. Okay. Everything I just went through, you can read through that. I'm not going to go through that again. But yeah. So back to type D. So moderate severe cases, these are the blue bloaters, right? So there are signs of cyanosis in these patients. If you do some respiratory gases, they have hypercapnia. Capnia, what's that mean? CO2, right? CO2 levels are increased. If CO2 levels are increased, who else is increased? Hydrogen ions increased, right? Because we haven't soaked it up by making CO2. So they're also going to have respiratory acidosis as well. Too much hydrogen ion. Okay. If you auscultate these people, they're going to have gunk, especially down at the calciphrenic angles. So you might hear crackles. So make sure you know what crackles. I mean, pneumonia also classically causes crackles. But remember the old AKAs, rails, which still might be around. So if they're dying, they might have rhonchi. Those are two adventitious sounds. So I got my adventitious sounds in here a little bit. And I don't know why I put that in there again, but just to show you again how the hydrogen ion, if you don't have this going, if you're not making CO2, because this is beaver dammed, the alveoli, you can't get much exchange going. There's just no way to get it in there. Then the hydrogen ion is going to just hang out, and the bicarbonate's just going to hang out. And so you're going to have acidosis if the bicarbonate and hydrogen ion builds out. Right, and carbonic acid, right? But I'm not going to go too crazy into chemistry here. It's better to think of it like that. Hey, we did it. That was the last lecture for this quarter for CVPP. Again, apologize for this crazy last week. I think probably a lot of the teachers are. I know if I'm stressed, I think everybody's probably stressed because I'm used to making these videos. But hang in there with us and stay safe. And I think you young people don't have too much to worry about. It's old people like us who have more to worry about. But I think we'll all make it through this, and we'll soon see you guys around campus again. All right? Any questions, as always, feel free to email me, and we will see you around.